Hi guys, welcome back. I hope you enjoyed your coffee. I know I'm on my 5th cup now, so that was nice. If you guys looked at your program guide, I know that it says that the next person to speak is Mallory Stradecke, who's a stage 4 stomach cancer patient. Unfortunately, Mallory is not able to present today. She's going through some health issues, and we wanted to respect that. She did submit something for our website in terms of her story, and we'd like to share that. We'd like to share that with you guys right now. My name is Mallory. I'm a 28-year-old mother of 3 young children and wife. On July 2015, when I was 26 years old, I was diagnosed with stage 4 cancer. It came as quite a shock, as I was otherwise a healthy person with little to no medical issues, an avid hiker, student, busy mother, healthy eater, etc. Earlier in the year, I had started having trouble swallowing. There was always a tight feeling going down, but still, I was able to eat, so I brushed it off. Eventually, it became more of a struggle, and even swallowing fluids became an issue. At the time, I was 32 weeks pregnant. I started complaining to my doctor, but because of my age and the fact that I was pregnant, it was brushed off by health professionals. It wasn't until I was 2 months postnatal and was having to make myself throw up because food would become so stuck in my esophagus that a barium swallow was scheduled for me. During the barium swallow, the radiologist immediately saw the mass where the esophagus meets the stomach, much to his surprise. He urgently scheduled me for endoscopy the following morning. They had to proceed with the endoscopy using a pediatric scope, as the adult size couldn't get past the tumor. Later that day, I was told that I have an angry, bleeding mass, and it was stomach cancer. We went ahead with a CT scan and laparoscopy to confirm that it had not spread. I was scheduled to begin neoadjuvant chemotherapy to shrink the mass before surgery. A few months later, after complications that involved dehydration, having a very painful stent fitted in my esophagus to open it up so I could eat, and a lot of hospital time and missing my children, I had surgery to remove most of my stomach and a large portion of my esophagus.
I had a large portion. Okay, sorry. Sorry, you'll have to kind of bear with us. Mallory has also been one of our initial members, and so she's very dear to us. So we wish her and her family. Anyway, my family hoped that the pathology would come back confirming an early diagnosis. But unfortunately, we discovered that even though they were able to remove all of the tumor with clear margins, I had a whopping 24 out of 40 lymph nodes positive for cancer, and the 8-centimeter tumor had invaded all layers of stomach and was touching my pancreas. Fortunately, I had an excellent and complete response to further chemo and was cautiously hoping that that meant permanent remission with 3 clear scans. I had a large portion of 2016 treatment-free and was even able to put cancer out of my mind for that time and focus on my children and loving life. During that year, we did find out through genetic testing that I have Lynch syndrome, which is why I got stomach cancer to begin with. It's a hereditary genetic mutation that increases your risk of many different types of cancer, mostly colon cancer. Eventually, the cancer did spread to my adrenal gland and lung by the end of the year in 2016. But with more chemo and radiation, a lot of support from the BC Cancer Agency, and friends and family, I am doing relatively well and have even stopped treatment for now. With pain from the very large mass that grew on my adrenal gland under control, thanks to radiation, I find I have less quality of life and more symptoms from treatment than the cancer itself. So we made the choice to stop chemo for now. I was also recently accepted into a trial offered only in BC at this time that has given us new hope that we may be able to find a personalized treatment plan that will help control the growth of the cancer, turning it into a more of a chronic but manageable disease, instead of one that has a very poor prognosis. It's a long process, but it gives patients a promising and hopeful new avenue to explore.
Like anyone who has dealt with cancer, having it has changed my life. Although terrifying and exhausting, it has also given me the opportunity to refocus on my priorities in life. I try not to take the little things for granted anymore and have realized that time is truly precious when you've been given a knowingly limited supply of it. I've made peace with the fact that I most likely won't live long enough because of cancer. And in the meantime, my goal is to learn to live as well as I can with it and be open to learning from it, instead of using my energy to hate it. I do hope that more than anything, with an advocacy for research and funding, which is huge parts and thanks to groups like MyGutFeeling, we can eventually find a cure for late-stage stomach cancer and create more tools to be able to detect stomach cancer earlier. Big hugs and lots of love goes out to anyone battling this disease or caring for someone who is. Hugs and kisses, Mallory. Mallory, whether you're watching this or not, we want you to know that we think about you every day. We realize the hell that you're going through. It absolutely can't be easy. And we want you to know that we do this for you. We do this for you and people like you. Your story has touched us in absolutely every way possible. And we wanted to dedicate today's conference, the first ever conference on stomach cancer specifically, to you and your family. Our thoughts and prayers are with you.
So on that note, I just wanted to call up the speakers from this morning, if they could come, and we'll just start the panel discussion. And anyone is free to ask questions or open a discussion. So if the speakers could come and just sit down and we'll open up. You okay? Yeah, good. Okay. So I'm going to join this one. Okay?
Sorry for that. Medical professionals and patient survivors and caregivers. Nobody's off the hook, guys. All right, so I'd like to just open it up to the floor. I mean, we've had a bunch of really excellent speakers, lots of information coming to you guys. Does anyone have any questions that are pending? Okay. So I would like to start off by asking kind of a genetic question. However, this is open not just to the geneticist and a medical oncologist and just healthcare professionals. We want to open it up also to our patient survivors and caregivers. So what we learned, what you guys might not realize is some of the younger members who've gone through genetic testing for genes in stomach cancer, those that have tested positive for a gene find it very frustrating that they cannot test their younger children. So in Canada, and please correct me if I'm wrong, genetic testing doesn't begin until you're 18 years old. So for those of you who have been diagnosed with a genetic disorder, how does that make you feel that you can't test your younger children? And alternatively, to the medical professionals, we'd like to ask, why can't we perform genetic testing on people that are under 18 years old?
We can give you the reason, but it might be nice to hear what people think about it. I don't know who you'd like to start with.
No, it's open to anyone, so go ahead.
So it's not entirely true that you can't test until age 18. In fact, some of the genetic conditions that affect children, like Peutz-Jeghers children, and other syndromes where you get lots of polyps in the colon, that will affect people under age 18. And so we definitely have to test them before they're 18 years old because there's medical intervention. The question becomes, if there's no medical intervention before age 18, and in fact, most of these syndromes don't impact your cancer risk until you're in your 40s or so, should we be testing children when they have no ability to make their own opinions? So there are ethic codes that say that people deserve to make their own decisions about their own medical care. They have to be able to give consent. And if a child is unable to give consent and there's no medical intervention, there's no treatment, there's no screening, and in fact it won't impact them to their adults, is it fair for their parents to make that decision when we could wait for them to be 18 or older and make their own decision? And I can tell you, some of these kids, when they grow up, they don't want to have the information. They feel psychologically it may be difficult for them to deal with until a certain time of their life, or maybe after they meet their spouse or partner to be, or maybe when they want to have children is the time. So they want to make their own mind up about when they want to find out about the mutations. So an example could be CDH1, where normally you aren't affected until you're older. Let's say you find out your 2-year-old has a CDH1 mutation. There's nothing that you can do for them until they're older. The cancer risk average age is about 38 years old to be diagnosed. We wouldn't start screening them until they're at least 20, even through gastroscopy or consider surgery. So if they're 2, as they're getting older, every time they get a stomach ache, the parents may be afraid, what if it's this, what if it's this? And let's say when the child turns 18, they say, I don't want to know this right now. I just want to live my teenage years because there's nothing I can do. And when I'm 20, maybe I'll be at an age where I'm able to think about the surgery because now there's something tangible I can do. And so there's a policy for most adult onset conditions, which is what we call it when you're not affected in childhood, there's no intervention or screening in childhood, that people have the right to make their own medical decisions when they're older. And usually the age of 18 is considered the age that you're able to give consent. If you're a 17-year-old and you're very eager to know and you're able to give assent, then we do that. So we have tested people younger, and certainly if someone came in and they said, and they're 17 and they have, and they go, I'm getting lots of stomach aches and I'm so scared, can you please test me? We always break the rules for things like that. So any kind of medical concern will trump any genetic testing age rule.
Okay.
That's sort of
And I think the other issue really comes down to people are worried about insurance issues. So for the longest time, actually, unfortunately, Canada has been a bit behind in terms of protecting patients with genetic conditions with respect to insurance. And I believe there's a private member's bill that did go through probably, I think, 6 months ago that does now protect people, but there are still conditions. So I have an example of a firefighter who has a family history of Lynch. And in British Columbia, if you're a firefighter and he was diagnosed with colon cancer, it's actually an occupational hazard. But he didn't want to be screened for Lynch because if it's found that he has a genetic predisposition, then his claim is then null and void. So we do have to look at also, we have to be more cognizant also of just the impact of cancer on people from a social perspective in terms of work, finances. I mean, this is huge impacts on people. The other issue is exactly, Melissa, correct? Sorry. I'm from BC. I'm learning everybody's names.
I know, of course.
I have a patient who has Lynch as well. It's always Lynch, sorry, and he has a 20-year-old daughter who is still humming and hawing about whether she wants to know, because then she's worried about having children, about choosing a partner, and figuring all of this out. To a certain extent, we are fortunate. We do have reproductive technology. You could probably do some in vitro screening for this now. I actually spoke to some of the fertility experts. We can actually screen for certain mutations. But then that brings up a whole host of other ethical issues. And this is a lot for anybody to process. Imagine a 20-year-old, you're just trying to, most 20-year-olds want to like go to Thailand, right, and live life. And to think about that you might have this genetic condition that you might pass on, how do you discuss this with a potential partner? That's a lot for someone to try and figure out. So that's why we don't necessarily give this to someone who's 6 years old unless it's going to affect someone from a pediatric point of view. And there are some patients who just don't want to know, and we'll just watch them carefully.
I think you also bring up a really good point, if I could just emphasize that, the prenatal genetic diagnosis. So there are ways to test embryos. If, for example, the concern is you don't want your child to inherit this genetic mutation, there are ways to go through in vitro fertilization process. You test the embryos, you select the embryos that don't carry Lynch syndrome or CDH1 mutation and so forth, and you implant the ones that are without the mutations, and that way it hopefully guarantees that your child will not inherit the mutation. And there's other ways to do things when women are pregnant, like amniocentesis and so forth. So if the concern is that you're worried about your child inheriting it, there are tests then, but it's once the child is born that they then have their own rights that we think about.
So the reason, is this on? Yep. Anyway, the reason I'm sitting up here, not because I'm an expert speaker, but I actually have Lynch syndrome. And so for me, when I was diagnosed with Lynch syndrome, it was a double-edged sword, because I finally had the answer as to why I'd been hit with cancer twice. But at the same time, it was like, oh, great, now I have susceptibility to a whole gamut of cancers. So I went through like a period where Lynch was always at the front. I was always thinking about it. It was like every time I got a headache, and still sometimes it happens, every time a stomach ache doesn't go away, or I'm, a headache, or my shoulder is bothering me. Because of this syndrome, you just have that, there's that extra added anxiety. But at the same time, the knowledge that I have this enabled me to at least understand, so have an answer, because a lot of people with cancer, they don't get the answer. So I got my answer, and it also sort of helped me to make sure that my family could, get the testing and deal with it if they had it or if they didn't. So for me, it is a double-edged sword, and most of the time I put it to the back, but some of the time, and I was at a recent education night on Lynch syndrome. My sister and I, we call it lurching Lynch, because it's kind of like always there, and then those days that you're not feeling great or something goes wrong in a blood test or something, it's like, oh God, it's back. So I can understand people that at 20 would not want to get tested. I can understand people at 30 who would not want to get tested. I got tested, I was in, I had already been diagnosed, and I wasn't going to have children, so for me it was okay. It also led me to have a preventative surgery, because endometrial cancer is one of the big ones that you get with Lynch syndrome. So I ended up having a full hysterectomy, and so for me that was an added safety. It was like, okay, I knocked off one of them that I know I'm not going to be susceptible to. So in that way, it gives you knowledge, and it gives you the basis to make, I think, better decisions about what you're going to do going forward.
Is the cost of testing an issue with having the testing done? Is it an expensive test, and that's one of the reasons that it's not done as often as it should?
So for Lynch syndrome, it's actually a fairly inexpensive test. We can test the tumors, but then you still need to get blood testing to actually test the germline. So in Manitoba, they actually have, for colon cancer, it's a reflexive program. So anyone under the age of 70 is actually, if you're diagnosed with colon cancer, your tumor's automatically tested. In British Columbia, it's been a slow process, but hopefully we have finally managed to get the funding from the Ministry of Health to actually have a reflexive program as well, because the honest truth is, as Teresa's outlined, it's about preventing cancers. We don't want people to get cancer. I would rather not see patients because they've had preventative surgery than to have to give chemo, and that's the most cost-effective way. In terms of other hereditary cancer syndromes, our current way of doing things is we wait till someone gets cancer and we look at family history and use that kind of pedigree to direct which tests. I think in the future you're going to see that change. We're probably going to start testing probably all cancer patients for hereditary syndromes at some point, because we are noticing we are missing people. So the problem is when we start picking up people which don't have a family history, we don't know what their true risk is. So there's a lot of information that we need to learn moving forward. And it's actually, I think from a hereditary side, it's a really exciting time in cancer. Is we're probably going to be able to help a lot more patients. We're going to be a little bit confused on what some of these mutations and the risks are, but hopefully we're going to prevent more cancers because of this.
So healthcare is provincial, as you know, so every province has their own rules about testing. In Ontario, we have been fighting for several years now to have every tumor, and usually you start with colorectal tumors, tested to see if there's features of Lynch syndrome. Not only because it's a good flag to identify who might be at risk for Lynch syndrome, but now we know there also might be flags for treatment like immunotherapy. It is not a provincial program yet to test every tumor, even colorectal tumors, which is the highest cancer that we see in Lynch, for these features. It's done hospital to hospital, sometimes based on oncology, trying to look at markers and so forth, but it's certainly not a province-wide thing, and that is because probably of money, and also you need a lot of evidence to show that it's a cost-effective thing to do before, at least in Ontario, before our government will implement it. So there's a lot of research, a lot of focus groups, then you do it in one little section of the province and so forth. So we are really, really hoping it grows out, but then it's not just colon we would want, it's also gastric cancer and endometrial cancer and ovarian cancer, and so then it becomes a fight for every cancer that we see in the spectrum. As far as tumor testing, as far as the blood tests, prices have gone down as far as genetic testing. But one of the problems in Ontario is that they don't offer the right panel of genes to look for gastric cancer. So they're missing some important genes that we want to test for. It's not offered in our province, which means we have to send the samples to the states, and we have to get the Ministry of Health to approve the cost of it before we're allowed to send it to the states. And the government has some qualifications on who we can test. So we can't just test anybody. They have to have enough of a risk that the government is saying, okay, we'll pay the $2,500 American to do that panel test. And so we can't test everybody who's unaffected, for example. They need to meet certain criteria. And even in our province, there's no government body that's telling us what those criteria need to be. So, so every clinic in the province will do things differently. Some don't do a whole panel, some will just do CDH1, some have different criteria than others. So I think we have some work to do, at least in Ontario, about getting everybody on the same page, lobbying our government to maybe get the testing done in-house so it's cheaper in Canada and easier, and starting to look at our tumor testing. It's always about money when it comes down to it eventually, right? So there is some money issues with it.
It's been taking me 5 years to get the provincial program, just to let you know.
So there's money issues in BC too, yeah.
But I think it's an important point that, we are doing in colon cancer, we call it reflex testing of our tumor samples. So if there is a deficiency of one of these enzymes, there's 5 that we test, that correlates with Lynch syndrome. Then that moves us forward to do an extra test and then possibly send to Melissa. So I refer most of my patients to Melissa. But you're right, in terms of gastric cancer, we should start thinking about reflex testing. And there is a study that we have just put forward to try to do that, and hopefully that will get some information for all of us. But you're right, it's very site-specific, very hospital-specific. and it's not yet standardized.
Okay, well, I think that's a great segue into my next question, which is kind of in the field of medical oncology. So you just mentioned that genetic screening is a great way to diagnose cancer at an early stage, that kind of thing. Is there any other screening that we can do for stomach cancer? And I'm kind of alluding to H. pylori.
So because in Canada, gastric cancer is a bit more of a rare phenotype, we haven't recommended like population screening. So in other words, H. pylori testing, scopes like they do in Asia. And that's mainly in Asia. There's tons of gastric cancer. I mean, the surgeons there do like 6 to 8 surgeries a day. So we're still trying to figure out what is the best way for screening. So currently in Canada, the recommendation from most of the expert bodies is not to implement a screening program just because not many patients end up getting gastric cancer, so we'd be screening a lot of people, so it is a cost thing. The real thing is probably education, though, is people who have symptoms of reflux, or if you notice food sticking, talk to your doctor sooner than later to get that scope done sooner than later. Because I think the number one thing I notice with most of the patients who see me is, I noticed I couldn't eat food for 6 to 8 months. I was losing lots of weight, and then I saw my doctor. It's more probably seeing the doctor earlier and not waiting 6 to 8 months. Normally when food sticks and you're losing weight, that's a red flag, and you'll get a scope quite quickly. So I don't know, Christine, if...
I think, Natalie, you can address this, I think, in your presentation, too, in terms of the cost of screening and all of that.
Yeah, no, I was going to talk about the cost of screening, but it is not effective, unfortunately, to screen for gastric cancer within North America because of the low incidence. So if you look at the incidence within Japan and Korea and China, it's about 10 times higher than it is here. So it's basically colon cancer is for us what gastric cancer is for them. So they screen for gastric, and colon cancer is rare, and we screen for colon cancer, and gastric cancer is rare. It's not cost effective, and it is a very invasive test to do for screening for the population. Hopefully with the testing for fecal occult blood and some of the molecular markers they're doing with that, perhaps we can find a mechanism to better screen for gastric cancer. Through the fecal occult blood process, and I know Cancer Care Ontario and Linda Rabinick's looking into that, but just generalized endoscopy is not going to work in North America because it's so rare. And unfortunately, I see the same thing. People who have symptoms for a very long period of time, and they felt unwell, or they were in a very odd age group, and who thinks of a 30-year-old who gets gastric cancer? I mean, that's incredibly rare, but that does happen, and by that point that it gets diagnosed, it's more advanced and it's more difficult for us to treat. I don't know that there's a simple solution for this.
No, I think you said like it's symptom driven really, so it's not necessarily screen, because sometimes when you have symptoms, you already have the disease. As you've heard from the stories, as weight loss, anemia, reflux, pain, all of these are all symptoms that probably should precipitate into having a scope or gastroscopy, right? Take a picture to ensure nothing is happening. Sometimes, we find something called intestinal metaplasia. That means it's like a pre-cancer. This is something that can lead to a cancer eventually. But we still don't know what to do with these patients and how often they need to be scoped. If intestinal metaplasia occurs in China or Japan or Korea, that patient will have a scope every 6 months. That's kind of their standard to follow these patients because the incidence is so much higher. So they're really, really followed closely there. They have the resources, but also, as Natalie said, this is a higher incidence in Asia compared to North America. So really right now it's symptom driven, and following if there's a GI bleed, as you've heard, is whether or not there's a positive fecal occult blood test. So that means you have to sample your stool, but you have to be over the age of 50. So it's not going to catch a younger population.
Yeah. It's kind of frustrating for a patient that's a younger patient to realize that, at the moment we don't have a lot of screening available. But hopefully with more research, one day we'll get there with stomach cancer. My next question, I guess, we heard a lot today about standard treatment, standard chemotherapy for stomach cancer versus clinical trials in stomach cancer. And it seems like our neighbors in the US, they seem to have a lot more options for stomach cancer, especially the later stages. And even within Canada, it seems like we have unequal access to the clinical trials and options. Why is that? Why does it seem that we're kind of a step behind the U.S. and how can patients, say in Ontario, access trials in BC? Is there any way to do that? And then from a patient perspective, how does that unequal access make you as a patient feel? I know it's a loaded question. Sorry.
So no, it's a very important question. So Canada in general is, and we're both clinical trialists, is typically a second thought after a trial's already initiated globally. Why is that? Because Canada performs exceptionally well in providing excellent data on patients. That costs money. And so running a clinical trial is very, very expensive. That being said, our population in Canada is a tenth that it is in the US. And the US health system is very different, as you're aware, than the Canadian health system. So there is always more, when a drug company or when there's a question to be asked, they're going to go to a site that has a bigger population, a higher incidence of the disease. And that's why typically a US will have more options and more clinical trials than Canada. But we are still strong contenders, we still run clinical trials, and we try to make it work that they're at different sites, we can move patients through the system. It's a very good question, why if I'm a patient in Toronto, I can't go to see Dr. Lim because he's just so much nicer and prettier and smarter. Why can't I go to Vancouver to go on clinical trial? So the big issue is indemnification. That means that number one is you're not a BC citizen, and therefore you don't have the legal support behind you as an Ontario citizen. That means your provincial funding for your health care is in Ontario. So I can't go to BC to be treated by Howie because I'm an Ontario citizen and I don't have that provincial money that I need to be treated at BC. So I've had patients move back and forth, and we typically have to wait 6 to 8 weeks for them to get their OHIP number in Ontario if they're coming from BC. Money moves with the patient. So money stays with that patient if you're provincial. Indemnification means the legalities of it, right? So if I send a patient there and they get sick and they die, who is responsible for that patient? So indemnification is another big issue in terms of clinical trials and the safety around them. I don't know if you know.
So I actually did my GI training in the States, and there's a reason why I'm back in Canada is actually a lot of healthcare in the States is salesmanship. It's a for-profit enterprise. So 30% of the patients don't even make it through the door to see me because they don't have health insurance. So they don't have any options and they just end up dying somewhere else. And of the patients that sometimes see you, they're there for a fifth opinion just because their health insurance policy can pay for everything. So there's a lot of illusions to the American healthcare system that you have choice, but to be honest, a lot of it is just like it's watching the TV commercials. This is going to save your life and pay me money. If you really look at our outcomes, Canada performs among some of the best in the world in terms of cancer care. Okay, and in terms of what we fund across Canada, we pretty much fund everything that makes a fairly dramatic difference in terms of the outcomes of cancer patients. there may be some things that we don't fund, and that's probably because it's a bit marginal or the cost effectiveness isn't quite there. Like, some of the drugs might be almost $200,000 a year to help you live another 6 weeks. Is that fair, where maybe we should use that money for prophylactic surgeries or something else? From a clinical trial perspective, we actually, as Christine says, we actually perform quite well, mainly because we are fairly multicultural, and we actually oddly perform pretty well in our gastric cancer trials. So there are a number of clinical trials that are being run in Canada for gastric cancer patients and gastroesophageal cancer. So there's, like in BC, we have one for immunotherapy after gastroesophageal junction cancer surgery. There is another trial with immunotherapy and novel compounds that I think is being opened up across the country. As I said, I sit on the NCI task force for clinical trial design, and that task force has been at it for like trying to figure out new trial designs, and we've only pumped out maybe 2 or 3 extra new trials because the field is changing so much. So from that perspective, I don't think we are suffering much from lack of clinical trials. I think there are some here. It's basically in the United States, you are talking about 10 times the population, so there is a few more trials that are open in the United States just because of the population. But for the ones probably that have a bigger impact, most trials are pretty much open here in Canada. The issue is once it opens up in Asia, because there's so many patients in Asia, some of these trials close within like 5 months just because they enroll all the patients immediately. But we've definitely contributed.
Amy, do you want to mention some? So Amy's from our clinical trials group. Another thing that we've done also is we've formed, so in Ontario, medical oncology is, there's treatment in multiple different cancer centers, especially in the GTA. So we formed, as the COMET Clinical Trials Consortium, which is a web-based e-referral system for oncologists and clinical research associates who can move patients through the system where a clinical trial is most appropriate for them.
That's a good point. I was actually going to mention that too, in terms of there is a referral network in the GTA for physicians to refer patients across to different institutions that offer promising clinical trials that may not be available where the patient kind of presents initially. And from a research perspective, I'm not a clinician, I manage trials. Often the trials that we get, I find in Canada, are of a really good quality. I attend meetings sometimes where I find American trials sometimes aren't really conducive to the Canadian landscape because of the health coverage that we do have here. So sometimes American patients are, I would imagine, who don't have coverage, more desperate for options. And so the trials we get here are of really good quality and are fair to patients, I find, as well, and don't necessarily have that element that can take advantage due to kind of the desperation to access care that they wouldn't otherwise get the chance to access. So I do feel that the quality of trials we have here is really, really strong.
The one thing I do want to say is that there's not a lot of clinical trials for gastric cancer. So I was researching, and I saw that out of, I think currently, over 4,000 clinical trials are going on, and about 1% of those are for stomach cancer. So for those of us, that's a really tough number to kind of take in. When you think like 4,000, there's like 40 some odd, I think, that are going on now.
Yeah, that's changing though, honestly.
And we're hoping it's changing, because it's really...
Because I can say, 10 years ago when we were treating patients with stomach cancer, there was almost nothing. There were like no clinical trials. And now, like at our center, we have 2 that are coming forward. You've got, I think, 3. So there's now lots of clinical trials that are asking very important questions and providing opportunities to try new targeted therapies. But you're right. I mean, I think it still needs to improve, but we are, yeah, it's better.
And I think actually, the biggest thing is health advocacy. So My Gut Feeling is great. There's Debbie's Dream Foundation in the United States. And if you've ever met Debbie Zellman, she is a force to be reckoned with. She has stage 4 gastric cancer as well, but she managed to lobby the federal government to increase research funding to gastric cancer to, I think, $30 or $40 million for the next year in research grants. So a lot of, governments actually don't listen to physicians, they listen to patients. And it is actually the most important thing is you guys hold the power, and advocacy groups can really help drive agendas, and that's really important.
I think
Next
that's
step.
some very hopeful news there. Thank you for sharing, guys. I would like to open the floor up again to the audience to ask any of our panel members if you have any questions. Okay. And just to remind the people that are watching online, you can actually also type questions at the bottom of your screen.
I actually had a question for Dr. Bresden. So towards the end of your presentation, you talked about 3 areas that you were going to be targeting, and I'm sorry, I don't remember them. So I was just wondering if you could just speak to that again.
Doing the molecular targets, the treatments.
Yeah, there was yes.
So there's about, I'd say now 13 to 15% of gastric cancers overexpress a certain protein called HER2, which I think you've heard about in the subsequent presentations. We have an antibody that targets that protein. And so there's been improvements in survival in the metastatic setting in this population. We haven't really moved that into the curative setting yet. I don't know why, but that's a clinical trial question that needs to be addressed. The other one is new blood vessel formation. So we know that as tumors outstrip their blood supply, they start growing, and so there's a signal inside the tumor to make new blood vessels. And a surgeon will tell you when they cut into a tumor, it's very bloody, like it just bleeds, because it's chaotic vasculature, chaotic blood vessels. And so we know that gastric cancer actually has a lot of this signal of this protein known as vascular endothelial growth factor, which is a protein that's a signal for new blood vessels to come into the tumor. And so now there is an antibody known as ramucirumab, which is actually made by Lilly, that is an antibody that targets new blood vessel formation, has been effective also in metastatic advanced gastric cancer. And there are clinical trials that are looking at where to position this treatment. Currently it is in second line, so after the disease progresses after 1 line of chemotherapy, it's treatment in second line, but now we're looking at moving into the forefront in first line therapy. And the third one was immunotherapy, so immuno-oncology. Basically, there's now new antibodies. We've seen extremely effective therapies in melanoma. We've seen it in kidney cancer. We've seen it in lung cancer, whereby it basically, these antibodies unmask the tumor to the immune system. Kind of similar way of, an easy way of saying it. Because if you think about it, a tumor, a cancer cell is self. It's your own cell, which somehow has changed, is mutated, and it starts growing. And the tumor is smart, is that it makes this cloak. It covers itself, so it evades the immune system to kill it off, that it's different. And so what these antibodies do through different mechanisms, but essentially they unmask the tumor to the immune system. And you've heard about Lynch syndrome, or these mismatch repair proteins. Deficiency in one of them actually is a target. That cancer cell looks a bit different, and it's a target to treat patients with immunotherapy. Did I answer your question?
Yes, it does. Thank you very much.
Are there any other questions? Yeah, go ahead. Oh, Sorry, we'll wait for the mic so that the people online can hear us. Giving our volunteers a good workout today. This is probably a good time to say thank you to all those that volunteered today.
Hi. So it seems like there's a lot of exciting advancement happening. What do you recommend from a patient's perspective to ensure that we have access to the most of options available within Ontario? So we're just at the beginning part of this, so what's the process that, like, to make sure that you're getting the most that you can? Does that make sense, what I'm asking?
Yeah, so I think, it's your medical team, right? So having a dialogue with your oncologist, with the surgeon, if you have a radiation oncologist, with a social worker, dietitian, and then, of course, support groups, right? There's a lot of information on the internet, right? So everybody goes to Dr. Google and they try to, figure out how to treat their cancer. And there's a lot of misinformation. And I think you mentioned it nicely in terms of navigating the system. But it's talking to other individuals. So the Canadian Cancer Society, you might not know this, but they actually have a buddy system. And so what they have been able to do is link individuals with the same diagnosis and same age and same sex, typically. And so that gives an opportunity for you to actually meet someone who's actually gone through something similar as yourself. So the Canadian Cancer Society is a really good website. There's also actually the BCCA has a phenomenal website. We use it. So if you want to look at British Columbia Cancer Agency, BCCA is another fantastic website. And then there's the National Cancer Institute of Canada, known as the NCIC or NCI. Those are, I think, really reputable, really good websites for information. And always bring, and we've always talked about this, bring a book with questions on it, because you always forget. You leave your doctor's office and then you have like a whole flurry of questions. And then, we get inundated sometimes with emails. I don't know if you're an oncologist.
My husband actually has a word for that. He says we need a mulligan when it comes
emails.
to...
But sometimes it's hard, right? So, I'll have a patient email me like 10 questions. I was like, I can't talk. I can't email this back. So it's like, let's have a conversation. So I think it's always having that conversation with your treating physicians. I don't know if you want to add something.
And I wanted to add too is the report with the healthcare team. Like it's crucial. If you trust your team, you trust that they have the best for you, and having that open dialogue, I think, is very reassuring with a team that you trust.
And so one of the things that MyGutFeeling does is to offer that information as well, in terms of, if you're in Ontario, and now we're going beyond that, but certain doctors, or if you want a second opinion, or if you're uncomfortable, and we come at it from a very personal perspective because we've all been there. So there's pretty much no question that anyone can ask any of us that are, not just Katy and I, but Jan, or Svetlana, who's one of our members as well, or there's many members. We've been through it all, and there's no question that's off limits to us. And we're hands-on, and we try to provide, the best information that we have, the information that we have access to. And we're always there to talk to you in terms of if you have just day-to-day questions as well, because I think in the beginning, that's a really important kind of thing, because you're so overwhelmed.
We also try and tell our patients they're their best advocates. So they should advocate for themselves. I never mind when people come in with a list of questions, or if they have something that they're not sure of, or they've looked something up on the internet they want to ask me about. I encourage them to do it. No one's going to know more about you or your diagnosis than you probably do. So if something doesn't feel right to you, or you wonder about something, ask about it, because you know yourself better, or your husband will know himself better than anyone else, and probably as his caregiver, you're right there with him knowing more. So I think the doctors rely on you to give them the information that they can also help you with. And we really encourage people to advocate for themselves. And even for family doctors, they really may not, you know, for hereditary syndrome specifically, these are rare things. You may be the only person that they know with this hereditary condition, and often you're gonna have to teach them something about it. So we try and give people the tools to help advocate for themselves too.
And the other thing is, because patients always compare, especially when you're in the chemo unit, it's not a one-size-fits-all. So although someone might be getting some certain chemo regimen, oxaliplatin, another patient might be getting something different, there are going to be differences based on the patient. So we do have to treat people like people. And so although maybe your husband's treating one way, that might be normal, and you can certainly ask your oncologist about that. I think pretty much every patient of mine has a book of some sort, and a list, or an iPhone or something full of questions, and that's normal.
All right, so if there's no further questions, it's my pleasure to announce that it is lunchtime, everyone's favorite time. Now, just to let you guys know, as people who don't have a stomach, myself and a lot of the people here in the audience, this meal and every meal that we eat can be a challenge. So we had you guys in mind when we designed the menu today. So with that, I'd like to announce lunch. Thank you very much to all our panelists and the audience for participating.